Hi, this is Dr. Padda, and today I'm going to talk about metainflammation. Metainflammation is a driver of chronic disease. The total economic cost of obesity is about $1.72 trillion per year, but it represents about 9.3% of the GDP. Poor diet is the leading cause of morbidity and mortality in the United States. This dietary intake, or this malnutrition, should really be considered the malnutrition of excess. Metainflammation is the common nexus to the epidemics of chronic pain, addiction, and obesity. Once you understand the underlying biological model, it provides an opportunity for disease reversal and modification. I think it's very important to have relevant disclosures that are specific to the field of nutrition. Historically, many people have duality of interest, and sometimes that duality can be as subtle as a religious background. It can also be as subtle as their own personal dietary decisions. And frequently, the dietary decisions of the individual are nearly held in religious esteem, such to the point that they may not themselves realize that they have a duality of interest. I accept no funding from any pharmaceutical company. I've never accepted any pharmaceutical funding with regards to any of the recommendations that we're going to be discussing today. I've never worked with any food manufacturer. And for me, I'm Sikh. I was born in North India. I'm not a Seventh-day Adventist. I went to medical school in Kansas City and graduated in 1988, and I was experimentally vegetarian for many years. I mostly am carnivorous now, but I continue to eat vegetables at a moderate degree. What I don't do, though, is consume tremendously high carbohydrates. I try to maintain a very low glycemic index and a very low glycemic load, and most of my intake of food typically is proteinaceous. So how did I get here? I started off in the world of pediatric anesthesia, and then eventually transitioned to interventional pain in the urban core. And I predominantly treated patients that were in a high Medicaid population. Many of them were indigent. I have been doing interventional pain for over 20 years. I've always used a minimal amount of opiate, if any at all. And most of my treatment revolves around doing interventional treatment, typically joint injections or radiofrequency neurolysis or minimally invasive procedures to relieve pain. But I noticed some commonality in the patients that I was treating. I could take patients with severe chronic pain and I could get some short-term symptom improvement with interventional procedures, but then they would recycle through the clinic. The adherence and the long-term treatment of these patients was poor if I didn't treat their underlying causes, and they had a commonality of underlying cause. And that's what confused me. As I was looking at my patients, it was pretty clear to me that my patients were a little different than everybody else's patients across the country in pain management, but they were maybe a little bit sicker as in terms of the general population. So in the general population, only about 12.2% of the patients are metabolically healthy. In the pain center, less than 3% of my patients are metabolically healthy. And I would tell you it's probably less than 1% of the chronic pain patients and less than 3% of the patients that have acute pain. And that's significantly different the general population of patients. In the general population, about 75% of patients are overweight or obese. More than 50% have prediabetes or diabetes, and at least a quarter of adult diabetics are undiagnosed. I can tell you that in my clinic population, over 60% of diabetics are undiagnosed when they come to me. So as I examined this, I asked myself, were these people having pain because they were just carrying a lot of extra load? Was this a biomechanical issue? Were they having pain because they didn't want to work? Was this an issue of a reduced work ethic? Was this a cause? Was this an effect? Did they have a food addiction because they seemed to be overweight? Did they just eat more food because they were more addicted? They had an issue? And then the other question was, if you don't have any money, how is it that you're that big? How do you get that big? And how do you get overweight if you don't have any money? Isn't money required to eat food? And so these were the patterns that I began to examine. At first, I thought, well, there must be other physicians out there. I must have physicians that I can rely on that have been down this road, and they might be able to tell me what's going on. That didn't get me very far, because the reality is that most physicians receive less than 3 hours of nutritional education throughout their entire career in medical school. And a Credit Suisse study analyzed the behavior and informational background of physicians and for other providers. And they found that 92% of physicians continue to believe that eating fat is what led to cardiovascular disease. And that simply is not true. We've known that's not true for about 10 years. More than half the physicians, 83% of physicians, in fact, thought that butter was worse than eating margarine. And margarine is a vegetable oil. And 2/3 of physicians thought that consuming vegetable oil was heart healthy. And we've proven a while ago that that simply is not true. I started to look at the biometrics of my patients. And like I said, 91% of them were overweight, but 9% were actually thin. What bound them together, though, was the metabolism. So that whether they were fat or thin, they had a significantly destroyed metabolism. And how did I know that? It's because I began measuring the biomarkers. I had been measuring their SAD rate and their CRP. I had started to measure hemoglobin A1C, and I started to look at insulin. Then I started to look at cholesterol, but not in the traditional sense of cholesterol. I viewed cholesterol as the thing that was carried around and was a biomarker for inflammation. Because after a while, after I began doing my readings, I realized that low-density lipoprotein, LDLP, was really a biomarker. I started to look at omega-6 to 3 ratios. Eventually, I started to look at GGT. And when I started to put all of these biomarkers together in combination and in context to my patients, then it provided me a lot more information. So the reality is that here I am treating these patients, and unfortunately what I've got is pain refugees. These patients have no place to go. And when they show up at my clinic, they've been put onto narcotics by their orthopod, or they've been put onto pain medication through their emergency room, or even by their primary care, and they're being pushed out of the clinic. And nearly 41% of them can never go back to their primary care. They're refugees from their own practices. They started off in one place and they end up with me, and now I have to figure out what to do. And they're refugees from treatment. So as I was analyzing this, I realized that simply the concept of obesity was far more complex than a single cause. And obesity is really something more akin to a complex adaptive system in which you have tremendous numbers of feedback. And in order to get to the catastrophe that I was seeing, which was obesity, hypertension, prediabetes, diabetes, comorbid addiction, and all of the other things, it was very complex. And there were a multitude of things that had gone wrong. And because it was so complex and there were so many multitude of things that had gone wrong, it was highly unlikely that a single magic bullet was going to be discovered. And if there was no single magic bullet, it was also highly unlikely that a pharmaceutical company was going to create a biological treatment that they could then patent that would treat this issue. And that's why obesity is so hard to treat, because there's no one issue. And in this particular case, it's not just obesity that you're treating. It's the underlying defect to the metabolism that's occurred. And that metabolism defect results in obesity in the vast majority of patients, but in some patients, it may not yet result in obesity. So some of the models that I ended up finally understanding and putting myself into context with, and then being able to explain it to my patients, was getting them to simply exchange the word insulin for the word fat storage hormone. As soon as I was able to get that through my own head and then get that through to my patients, that every time they released insulin, whatever circulating glucose was in the bloodstream would then be shoveled into fat storage or glycogen storage, whatever storage mechanism it initially went into. It would create a decrease in glucose in the bloodstream, but an increase of storage of fat or glycogen in tissue in the presence of insulin. And if insulin was gone, then that storage depot would lyse. And some of that storage depot would be converted into glucose, and some of it would be converted into ketones, and it could be used by the mitochondria. So that was the crux of the model that I had to convey to my patients. And it was the issue that I never quite understood when I was going through medical school. And once you replace the word insulin with fat storage hormone or storage hormone, it makes the entire field more transparent. The other part of the model that I had been missing was that glycogen is stored predominantly in liver and stored to some degree in muscle, but there's a limited capacity of glycogen storage. It's about 500 grams, which is about 2,000 kilocalories. And once you exceed that glycogen storage, the rest of it overflows to fat storage, and there's nearly unlimited fat storage. You might have 40, 50, 100 kilograms of fat storage in somebody. And so the real issue becomes that if you never deplete your glycogen reserve, everything that you add on top of it instantaneously goes to fat storage. And that's the main issue. And that's, once I understood the combination of insulin being a storage hormone and the fact that you have limitations in your glycogen storage, then it became much more evident what was going on in my patients. If you have any questions, please feel free to reach out to me. We don't sell anything. We give our protocols away for free. If anybody has any questions, please give me a ring. Thank you so much.